Hello, everyone, and welcome to this panel discussion on the Voice of Healthcare platform. I'm Dr. Sarika Gupta, your host for the day. Today is 8th of June, the World Brain Tumor Day. The World Brain Tumor Day was, in fact, initially started by the German Brain Tumor Association to raise awareness about brain tumors amongst the general masses. It's a trend that's caught on worldwide, and every year, Brain Tumor Day is celebrated all over, just trying to raise awareness, stop the misconceptions, and bust some of the myths that prevail amongst the people about brain tumors. Some of the common ones being, are brain tumors always cancerous? Or for that matter, does the diagnosis of a brain tumor mean a death sentence? We're going to try and answer some of those questions and more. We have a very expert panel with us today. We are honored to have with us Dr. Professor V.S. Mehta. He's the chairman of Neurosciences at the Paras Hospital, Gurugram. Dr. Gaurav Jaiswal is the professor of neurosurgery at R&T Medical College in Rajasthan. Dr. Anil Kumar Kansal, who is the senior director and HOD neurosurgery at the 𝐏𝐵𝐿𝐾 Super Speciality Hospital, New Delhi, and Dr. Srikanth Reddy, who's a consultant neurosurgery at the Medicover Hospital in Hyderabad. We are very happy to have you all on board, sir, and I would request everyone to briefly introduce yourselves, please.
Dr. V.S. Mehta, he has already told you. I've been in neurosurgery now more than 45 years, and I was earlier at All India Institute. Now connected with the hospital.
Thank you, sir. Dr. Kansal, we would like to know a little more about you.
Yeah, I'm Dr. Anil Kansal. I'm working with the B.L. Kapoor Hospital for the last 4 years. I'm a HOD and director here. But I passed my for 2001 from the 𝐏�0𝐶 Lucknow, and I've worked in different hospitals in Delhi for the last 20 years.
Wonderful. Dr. Gaurav and Dr. Srikanth, we're coming to you now.
Yeah. Hi, I'm Dr. Gaurav Jaiswal, at R&T Medical College, Udaipur for the last 9 years. The type of setting I'm working in is usually cater most of the tribal and rural population. Yeah.
Dr. Srikanth?
Hi, myself, Dr. Srikanth Reddy. I'm from Hyderabad. I work at Medicover Hospital's high-tech city in Hyderabad. It is one of the
there is a link problem, I
private
think.
corporate hospital which is coming up. I have been here for past 10 years. Can you hear me, Miss?
Yes, I can hear you.
Sarika?
Yes, I can hear you. Yes, I can hear you.
Yeah.
So it's wonderful to have. Yeah, sure. Thank you. It's wonderful to have everybody from different parts of the country, from different streams of practice. We have, urban areas covered and rural areas covered, and we will want to know everybody's perspective on the various questions that we're going to ask. So the first question I addressed to Dr. Anil Kansal. How common are brain tumors in the Indian population actually? Are they really common? How often do we see them? What is the incidence like? Dr. Kansal, can you hear me? Dr. Kansal, can you hear me? No. I think there's a network
Because exact percentage in Indian setup is very difficult.
Okay. Your voice is breaking. So can you come back again, please?
Yeah, it's because exact incidence is difficult to tell in Indian population because we are not making much data on it. But problem is that incidence has definitely increased in last 10-20 years. Maybe due to the cases have been increasing, or maybe the diagnostic modality is increasing. That's why we are encountered more patients. Like in our setup, we are operating around 40-50 cases of tumors in a 1 month. And I think daily we might be operating 400-500 cases in a month of tumors. So this is a quite big number here.
Right. Dr. Srikanth, this is a question to you.
Yes.
Is the incidence of brain tumors specific to any gender? Is it related to any particular demography? Do you see a connection with the geographical distribution?
Yes, rather than going by the geographical issue, when we see, we have like our Dr. Anil Kansal has said, the demography per se in India, exact incidents, at least in the developing nations, have been not been thoroughly verified. But when we see the data overall, we have what we call BTEC, Brain Tumor Epidemiology Consortium. So what they does is they the multiple countries. They form a group and they try to analyze the data of these brain tumors. So overall, when we see at a global incidence, when we say incidence, when we have this global age stratified or standardized age, we have an average incidence of about 3.7 cases per lakh population in males, and in females it is 2.6 cases. So when we see roughly, it is corresponding to around 3.2, 3.25 to 3.5 cases per 1 lakh population. And definitely males are more prone than females. Again, we go by, when we say demographies, we have multiple. When we say brain tumors, we can have a primary, malignant, non-malignant, or it could be a secondary,
Yeah.
either it could be a meds, or sometimes we can have an even pediatric population.
Right.
So basically, it is proved beyond that children, it is one of the most common incidents. When we see that overall, like tumors in children, this roughly corresponds around 20 to 25% brain tumors. When we see that the
Okay.
adults at the same time, they correspond around 2 to 5% primary brain tumors. So predominantly, they play a bigger role in children, and the same has been with the as an we have this incidence increasing either because of what do we call diagnostic modalities, like previously Dr. Anil has said. So we are coming up and the incidence is increasing even in developed countries. So
Mm-hmm.
this is what the demographics and general gender plays a role in brain tumors.
So, I got your point that the brain tumors in a pediatric population would probably make up a large percentage of the overall cancers or overall malignancies. But my question also is that, in the older age group, is there any particular pattern? Do we see the tumors more commonly in the elderly, for example? I'm talking from
Yes,
one would be the primary brain tumors and one would be the say the secondary brain tumors which come from the other parts of the body.
yes. Yes,
Okay.
yes. So as the age increases, the definitely the tumor incidence increases. So we see in elderly population, the one of the established risk factors, the predisposing risk factors, what we call the age is one of the factor where increasing age, the likely chance of having an brain tumor are more. So male patient with an increasing age are definitely more prone for an having a malignant brain tumor.
Fine.
Yeah.
So, Dr. Mehta, sir, I'm coming to you. What are the factors that are considered to be causative of brain tumors? Are there any factors that we can really put down and say that, okay, these are the factors that could possibly be the etiological reasons why brain tumors are happening?
Well, there is no definite cause which is attributed to cause a particular type of brain tumor. But certainly, we would say, for example, there are certain genetic conditions like tuberous sclerosis or fibrosis, which can have more common like neuromas or tumors like.
Yeah.
On the other hand, as you already said, that with the age, in the elder people or the advanced age, metastasis is more common.
Right.
Family, and in one person, the history of tumors would probably have more chances of tumors in his lifetime. And certain,
Okay.
uh, like X-rays, radiation, they are also has been found to have some contributory factors to these brain tumors.
Right. And a common question asked, and in fact, a lot of people generally think that use of mobile phones is associated with brain tumors. Is there any documented evidence for that?
Don't think there are any documented proof for that the mobile phone use causes brain tumor. And even to study this, that mobile phone causes, you need very long study to prove that it has.
Yeah,
Uh,
yeah. It would be really hard to prove it. Yes. Yeah, I understand. Dr. Gaurav Jaiswal, I come to you. What are the different types of brain tumors? Can you kind of give us a overall classification or a overall understanding of how brain tumors of different kinds happen? I can't hear you, Dr. Gaurav. You're muted.
No,
Yeah.
it's not. Hello. Am I audible?
Now we can hear you. Yes, now we can hear you.
Hello. Okay. Well, the brain tumors are of several kinds, and one shouldn't be too nihilistic about these brain tumors. The classification we follow as neurosurgeons and my neuropathologist colleague was devised and then again revised further in year 2016 by WHO, that is World Health Organization. For the first time in year 2016, the WHO nosology takes genetic markers into account in classifying these brain tumor. And the classification we are right, the current classification system has ICD coding for more than 150 varieties of brain tumor, just to streamline the management protocol and final outcome of the disease. So still the nomenclature of the tumor is primarily based upon the cell of the origin. Like to start with, these are first group the WHO has devised diffuse astrocytic and oligodendroglial tumor, which includes majority of the tumor that include astrocytomas, oligodendrogliomas, and glioblastomas. Then
So for the
comes
common
the
people, sorry to interrupt, this would be tumors arising from the brain cells, right? I mean, typically what a normal person would understand, right? Yeah.
This is a broad classification, glioma. These
Yeah, right,
all include
right.
glioma. Then
Yeah,
the
sorry.
tumor
Yeah.
come from the ependymal tumors, ependymal cell lining, which line the ventricle. These includes
Yeah.
subependymoma, myxopapillary ependymoma, and anaplastic variety is also there. And again, the anatomical structure, choroid plexus is there. The tumor
Right.
which arises from the choroid plexus are of different type and of different
Right.
grades. So there are group of tumors which include the pineal region. There are tumors of cranial and paraspinal nerve, which include vestibular schwannomas and other schwannomas. Then there are tumor of meninges, which include vast variety of the meningiomas. Then there are lymphomas, germ cell tumor, and so many, including metastasis, which is last on the classification. And
Which is, of course, the tumors that come from outside the brain, right?
yeah. And for
Yeah,
the purpose of understanding, just to brief up, for the purpose of understanding, majority of these tumors from different cell lines and their subsets has been divided into 4 categories. That
Okay.
depends upon many histological events like mitotic figure and all that. Grade 1, grade 2, 3, and 4. Broadly, I would like to emphasize that grade 1 and grade 2 tumors, they are somewhat curable. And grade 3 and grade 4, though may not be curable, can be controlled for a reasonable duration in some cases. So this is the broad classification. Yeah.
So that also means that if you're diagnosed with a grade 1 or grade 2 tumor and you're diagnosed with a tumor which is a relatively better prognosis, it means that it is curable, right? I mean, this is a
Yeah.
very
Yeah.
common myth that a brain tumor diagnosis just means it's a sinister thing and it'll always end up badly.
No, it's not that way. It's not that way. That depend upon the so many factors: genetic factor, histology of the tumor, and the time of the time of presentation of the patient. There are so many factors, and just what I've said, one shouldn't be too nihilistic about these brain tumor.
Right.
Every tumor protocol, every tumor treatment has different protocol. Yeah.
Yeah. So carrying from your previous statement about the patient's presenting symptoms, now what are the red herring symptoms? We commonly have people coming with headache and, very non-specific symptoms sometimes when they just pop a pill and say that, it is just a regular headache. And of course, there are a whole lot of headaches that happen because of non-tumorous causes. But
Yeah.
the question is that, what is the red herring symptom when the patient should, or symptoms when the patient should think that, this could possibly be a tumor and the patient needs to really take it seriously?
Well, it's very difficult for the patient to diagnose himself or to put to the neurosurgeon at first go. And what you are saying, the headache, the symptom and sign are related to the substrate involved and can be atypical also. So they could be quite ubiquitous, and in rural setup like me, the place I'm working, the presentation is very late. Again, the headache, though vague, is one of the main symptom and can be with or without raised ICP. Whenever there is raised ICP, this is the alarming sign. So
Yeah.
again, what we have been taught in our UG classes, the headache for the brain tumor, which it has been described as being worse in the morning, often exaggerated by coughing, straining, bending forward, or placing head in dependent position, associated with nausea and vomiting, and relieved transiently by vomiting. So we don't see such type of headache in our routine practice. The patient usually got referred from us to us, either from the physician or from the neurologist or from the pediatrician. Okay. Again, just I would like to emphasize the pathophysiology. Just a brief review. Per se, the brain tissue itself is not pain sensitive. Okay. So what is the causes of raised ICP? What are the causes of raised intracranial pressure? It could be because of the mass effect of the tumor or surrounding edema, or it could be due to the hemorrhage inside the tumor, or the majority of the pediatric patient in posterior fossa tumor, they present to us with the hydrocephalus, okay, which again could be most of the time it is obstructive. Then comes the compression on the invasion of just I'm trying to elicit the etiology of the headache. Then comes the compression upon the invasion of the pain sensitive structure like dura, blood vessel, and periosteum. Then headache, again, it could be involvement of the various cranial nerve, 3, 4, 6, or could be internuclear ophthalmoplegia. So these are the various type of presentation for the, again, for the, in the adult patient, sometime patient presented with the, even in the pediatric patient, the patient presented with the focal motor deficit or disturbance of speech. Hello. And again, due to the involvement of cranial nerve involvement, like hearing loss. One of the, again, presentation with the seizure. This is not the infrequent, the first symptom of the brain tumor. Tumor should be aggressively sought for in a patient for the first time seizure, especially in the adult, rather any patient. Okay. And even if the imaging study is equivocal and negative, for the adult onset seizure, the patient should be followed up with the repeat studies. Again, patient can again present with the endocrine disturbances in case of pituitary tumor. Again, patient can have pituitary apoplexy, or rare presentation could be the CSF leak. These are the
I
various
think
modes
the
of presentation.
presentation can be extremely variable. That's the model of what you're saying, and therefore the patient has to view his symptoms, get himself examined by a physician, and maybe get some imaging done to rule that out in case of that. In fact, this is not, it was good to hear from you the perspective coming from a background where the patients, of course, are presenting late. But I would also want to know from Dr. Mehta sir first, and then Dr. Anil, what is the presentation in urban areas like? Because you are both practicing in a very relatively more aware community. So do you see a very late presentation, or do you see patients coming in early also? Mehta sir, first to you.
Well, this all depends on the location of the tumor and the nature of the tumor.
Right.
If the nature is highly malignant, then probably they will have very short history and they will present very quickly.
Right. Yeah.
But if it's a benign lesion, then the brain has the ability to compensate the symptom. And sometimes we have seen, even in educated population, with a large tumor without much significant symptoms. So what I would say is, any symptoms, as you said, headache, which remains persistent, don't ignore it. If the headache is progressively worsening, don't ignore it. So, and if they are associated with other symptoms like vision disturbances or vomiting, of course, they are hallmark of the brain tumor.
Right. Thank you for summarizing it so well, sir. Dr. Kansal, what is your experience?
And now this is depend which symptoms the patient are presenting. Like if they're presenting with seizures, they come early to us because they get scan done. Because in the urban area, this is the advantage that we got a CT scan and MRI. Now every physician is aware if they got seizures, uncontrolled headaches, severe repeated headaches, they get a scan done and the patient comes. But sometimes the symptoms are very less. Even the large tumors also comes because the patient are ignoring their symptoms. So mixed crowd we are getting in the big cities. But yeah, some patient we get in early stage because of better diagnostic facilities here in the city.
Yeah, okay. And Dr. Srikanth, is there any demographic difference? Do we see patients being more aware in South India? Are they the same? It's the same situation there that you're hearing from others, or is it any different? Anything notable and different?
Yeah. See, my practice being predominant in the South India, I would not be able to judge by this thing. But nowadays, like previously, my co-panelist has said, the awareness has increased. Like I was telling in incidence, even in developed countries, the incidence is more. When the world average is around 3.5 to 4, but in developed countries it is around 6 cases per lakh population. This is happening only because of the development of the technology, availability of the facilities, and previously to get an MRI scan, people need to travel to nook and corner or to only specified places. But even in nowadays with the development, we have MRIs in each and every nook and corner in and around us. So,
Yeah.
and people are now aware because of this multiple platforms. They won't hesitate to get an MRI done. In that
Yeah.
scenario, yeah, definitely we are coming across. Depending demography, yeah, if within the city limits, they come up early. But where from the rural areas or from the peripheries where they ignore the initial symptoms and they have been
Right.
given some painkillers or some other medication by the treating
Yeah.
doctors
Look
from
at
the
it.
native places, they do present late.
Right.
And
Right.
most importantly, like our Dr. Mehta sir has said, it is the location which determines how early they are going to present.
Yeah, yeah, yeah. That totally makes sense. And in fact, the incidence of a disease in a population not only depends upon the actual incidence, it also depends upon how much it's really diagnosed. So that's another thing that we often face in developing countries. We have a fallaciously low incidence of certain disease because they're never really diagnosed. But things are changing, especially in the urban India, things are changing. So that brings me to another question, Dr. Srikanth, to you. What are the various methods that are used for the diagnosis of brain tumor? We commonly hear about CT scan and MRI. When is what's supposed to be done?
See, there are two things when we say diagnosis. First, whenever we see patient as a primary doctor, it is basically we go by the symptoms. Okay, initial scan
Right.
to ask for a patient would be when we are going with the symptoms could be based upon the symptoms. For example, a patient coming with a plain simple headache, but changing in character, gradually progressive in nature, or non-bearable. So initially we might go with a CT scan. But a patient coming with an functional loss, when we say a neurological involvement, either it could be a weakness of limbs, loss of cranial nerve, anything like that, something which is very significant in our clinical examination. Based on that, we might ask for an MRI. So once we establish there is some abnormality, structural abnormality in the brain, this is where a whole further workup starts. People, we do see people, so CT scan is done, why do you need an MRI and all that? But
Yeah.
the story doesn't end there. Initial is what we see is to identify the cause. And second thing is once we know cause is there, that's the whole scenario starts. That is like we do an MRI, both plain and contrast, and along with that we do a spectroscopy. That means we come to know how severe or how malignant the lesion is. Spectroscopy, either it is an infectious disease or an causing a lesion, or it is an proper tumor, malignant or non-malignant. Again, based upon the contrast uptake, we will try to categorize it into low grade or high grade. And next comes depending upon the location, we might have to require a functional MRI so that if when it is near motor cortex or speech area, we might have to plan for an awake surgery where we need to do this. And sometimes we have to go with tractography. All these are different modalities of MRI where we are going
Mhm.
to improve the surgical outcome. And this
Right.
includes angiography also. So
Right.
diagnosing is one part and further workup, but predominantly it is MR based investigations for a brain tumor.
Right. So yeah, basically to first diagnose and then to ensure a good outcome, you need more imaging to
Yes.
not just diagnose, to go ahead and actually see the tracks and everything. Dr. V.S. Mehta, I come to you, sir. Once the tumor is diagnosed, now first of all, what are the various options that the patient has? I'm focusing more on the surgical options here. And what is the new thing in the neurosurgeon's OT that's happened in the last few years? You were a stalwart, you've been practicing neurosurgery for so long. What are the changes that you've witnessed over the years in the neurosurgery ORs?
The neurosurgery have changed tremendously. I mean, today, when I say neurosurgery is as safe as any other surgery, provided your patient comes in time. That's the most.
Right.
Patient is late and there is already gross neurological deficit, that means some of the functions are already eaten away by the tumor, then you can't get that back. But if
Right.
patients with all these investigation which Dr. Srikanth has narrated, we can localize the lesions very well and we can plan your surgery very well. Now, as far as OT equipment is concerned, again, the best equipment is, of course, the surgeon himself. If
Yes.
surgeon technically has to be sound and he should know when to stop and when not to stop in the neurosurgery, because you should not do harm to the patient. That's the most important. And with all these investigations, we can localize these tumors. And then, of course, in operation theater today, we have all the equipment like coming basically from the bipolar cortex that are also microscope, image guided CUSA, and whatnot. And intraoperative MRIs, all these help in protecting your brain functions and giving good results.
Right. Right. So these are huge advances coming from the time of initially when the brain tumor surgeries usually were associated with very high morbidity, if not mortality. Things have really changed over the years, and we do see patients recovering really well. The key, of course, being that the patients come to you early, right? I mean, that's what
Yes.
the moral of the story is really.
Today we
So
have the brain stem, which was considered as no man's land. With all intraoperative monitoring, electrophysiological monitoring, and all the equipment, armamentarium, we can remove them without producing harm.
yes, thank you, sir. Dr. Kansal, I come to you. Can you tell me about the newer, the non-surgical treatment methods that are now being talked about? We have stereotactic surgery, gamma knife versus Cyberknife. Can you briefly explain about all these modalities in a little more detail for the common people to understand?
Yeah, there's two kind of tumors. One is malignant and one is benign. Sometimes we just like observe for the some patient which are small tumors, benign tumors. We don't do anything, just give medicine for seizure and anything. The other tumors are which can be resolved by the gamma knife single dose radiations. That doesn't, and because surgery carries high risk, so we can give like gamma knife and the cyber knife. This is part of the radio surgery where we give high dose of radiation in single sitting or 2 or 3 sittings, and the tumor gradually decreases, like CP angle tumors, small meningiomas, pituitary tumors, which are not touching to the optic chiasm or eye nerves, that we can give by this. And the one is that when the tumor is a deep seated, sometimes we don't want to do surgery because of a lot of neurological deficit comes. So we can take
Right,
a stereotactic biopsy and refer to the radiotherapy.
right,
These are the tumors which are modalities coming. Now, one is a neuronavigation is coming. If we can assist by that, if we had really planned to complete excision of tumor, we can store the all images in the computer images on the machine computerized, and then we can localize during the surgery what amount of the tumor we have taken, or intraoperative MRI we can use it.
Mm-hmm. Okay.
These are
So,
the
for this is a very commonly asked question. How is a cyber knife? What is the difference between a cyber knife and a gamma knife?
because this is a mode of because we give a mode of radiation is a part of radiation. One we give a like modified linear accelerator, or one we give the gamma knife grids, because that is a mode of different. And second is cyber knife we can use in a different part of the body. Gamma knife was originally designed for the brain.
Okay.
That is the
Okay.
advantage, because in
So,
this there's
can you give me examples of any specific types of, other than of course the brain tumors which may be located in critical areas and you just can't go there, but what are the other types of tumors? Are there any specific tumors that respond better to these treatments?
like schwannomas, they respond well. In the spinal
Yeah.
tumor, sometimes schwannomas there we can't resect completely. They can be sent to cyber knife, because spine we can't use gamma knife. The cyber knife is a better option. Like CP angle tumors, if the small tumors or residual tumors, we can either do gamma knife or cyber knife in this. They respond well to the tumors.
Okay. So neuromas basically you're
And
saying they
second is the
respond.
metastatic tumors, small lesion,
Mhm.
multiple metastatic, they respond to the radiosurgery very well. And the AV malformation tumors, is not considered tumor, AV malformation, they also respond very well to the cyber knife and gamma knife.
Right. Okay. Thank you. So, Mehta sir, I've come back to you. Are there, are there any kinds of tumors where we can say that, okay, fine, these tumors have a good prognosis and these tumors have a bad prognosis? So, does the histology and the diagnosis make a big difference?
Depends on where is the tumor located and
Right.
of at what stage the patient arrived. So basically, we will say that benign tumors have good prognosis, cancerous tumors have bad prognosis. But again, as I said, if suppose even benign tumor is located in strategically located area where internal carotid arteries engage or some important structures are engaged, and if again depending on surgeon's experience and correct approach, the prognosis can vary. So most of the cancerous tumors, high-grade gliomas or grade 3 tumors or gliomas as such, initially doctor said that grade 1 and 2, we can give a good prognosis, whereas grade 3 and 4 are a bad prognosis. Even in cancerous tumors like lymphomas, they are considered to be cancerous tumors, but they will respond very well to radiotherapy or a chemotherapy, and if indicated, the radiotherapy. So it
Right.
depends on several factors about the prognosis of these tumors.
Right. Right. Dr. Gaurav,
Yeah.
you were talking about the stages of the tumor or the grades of the tumors. Can we kind of stage brain tumors the way cancers are staged in the rest of the body?
So, what actually the staging process is, it assesses the spread of cancer beyond the original sites. Okay, cancer like in other part of the body like lung, colon, and breast, they are staged based upon the location of in the body, their size, and lymph node involvement and possible spread. But the brain tumor, they are altogether different entity. They don't behave in the same way as other cancer does. They do. Like the type of cancer I have mentioned, tumor may migrate within the brain from other sources. Okay. But it is
Right.
very, very rare for the primary brain tumors to spread outside the confines of the CNS or away
Right.
from the central nervous system. So consequently, what I've told, the brain tumors are graded rather than staged.
Right. Right. I get your point.
Professor Mehta already told grade 1, 2, they are relatively low grade tumor, and 3 or 4 they are having malignant potential. 3 and 4 rather they are malignant
Right.
variety.
Right. Okay. So, I, what I would in fact want to know from you, first of all, are there any precautions that we can advise to people where how to prevent brain tumors? I mean, is there any really method to do that, or is it like, it's just a matter of luck? Dr. Srikanth, I come to you.
Yeah. Hi. When it comes to precautions, like previously we were discussing, sometimes some tumors could be because of genetic origin. So when we say
Right.
genetic, like we can do a genetic screening so that they can be a preventive uh, as a measure. So when we know that there is some sort of disease running in our families, where we can do a genetic predisposition is there, we get a genetic evaluation, and thereby preventing that to happen. That is one sort. But strictly speaking, as we know nowadays, we are coming up with things like that because of late we have seen, at least in India, we have seen GBM, brain tumors, more common in workers working in Jammu and Kashmir in apple orchids. So that there was some association with the type of chemical which they use in those farms, like organic farms. So we need to again still evolve in that matter. So as of now, strictly speaking, there are no precautionary measures. But with the advent of this development, with the additives, the food we take, and the healthy habits we have, so all this going to matter a lot when we say precautionary measures because we exactly don't know what is triggering this and what is causing this. But one trend which is commonly observed or thought so is we see as the tendency is increase in developing countries. They also attributed it to the what do you call the lifestyle changes. Okay, like
Right.
the additives, food additives and all, they can be sometimes could be the trigger of developing a brain tumor. So overall, we need to have a healthy lifestyle, eat less of a processed food, and keep ourselves fit and healthy. And again, weight and underlying associated disease also sometimes are vaguely related to this disease, but not have been confirmed till date.
Right. So basically, you mean to say the general health
Yeah.
measures that we all talk about, maintaining a healthy lifestyle, eating less processed
Yes.
food, not
Yes.
mindlessly adopting the Western methods, and at the same time, but that's all we can do really, because there doesn't seem to be any other significant factor that can, we can really prevent. So,
Yes.
I would want to come back to Dr. Mehta and everyone else and ask you, what do you think, sir, should be the message for the community on the World Brain Tumor Day?
Well, my message would be that don't ignore your symptoms. First, public went as we already expect the brain tumor. Don't ignore. If there is any family history, your mother or father, but chances are slightly higher over the normal population. But so do not
Right.
ignore symptoms. Go to the doctor, investigate it. That's it.
Sure. Thank you, sir. Dr. Kansal, I come to you. Do you have a message to give to the public? What should be the message on this World Brain Tumor Day?
Brain tumors are the same kind of disease, just other disease in the body.
Right.
I just want to say the brain tumors are the same kind of disease other diseases have in the body. They can be
Okay.
cured if we come early and diagnose early and treat it. If we diagnose
Right.
late also, we can give a few years of good life to the patient if we cure properly manage that patient. So don't afraid of the brain tumors. If anybody gets symptom or diagnosed, please come to the doctor early and get the test done so we can manage that patient early. This is good.
Right.
And one thing more, the
Yeah.
surgical results are excellent
The
of
model.
the brain tumors in every good hospital. There is not to afraid about the brain surgery. Thank you.
Right. Thank you. Dr. Gaurav, I come to you with any last message?
Yeah, just not to lose hope, even
Yeah.
when the patient are diagnosed with the brain tumor, just not to lose hope. Go to the you are treating consultant and go by their advice. With the modern days neurosurgery with advanced all type of OT armamentarium, majority of the brain tumor, they do have very good prognosis if diagnosed earlier and the patient comes in on time.
Yes. And Dr. Srikanth, from you?
Yeah, definitely. From my end, people don't get panic. So brain tumor is not end of your life. Like previously Dr. Gaurav has said, these days with the development of this latest, you can say gadgets or overall development, the neurosurgery, principles of operating or overall things which are contributing for overall good outcome. Like previously discussed, not all brain tumors are bad. 80% of them are benign and they can be treated well. Main thing which you should keep in mind is like detect early, act early, don't delay for them to become worse in the process of making up your mind or getting panic. Yeah, this is it, my life is. Except for the few percentages, I think majority of them do well with so many armamentarium of gadgets and the treating approaches and adjuvant therapies. Definitely, I would say compared to other malignant conditions, brain tumors have been quite dealt very effectively these days.
Okay. So that brings us to the end of this very informative panel discussion. I think I would want to briefly say at the end that the general message remains the same as it's everywhere. Maintain a healthy lifestyle, watch out for the symptoms, report to the doctor early, and follow the doctor's advice. At the end of the day, that's what's going to help you. The diagnosis of a brain tumor should not be nihilistic, as Dr. Gaurav says, and I rightly agree with him that a whole lot of them can be treated and managed really well, especially with the newer advances. Sometimes you might even be able to have a treatment without a surgery if you're diagnosed with a very small brain tumor. Thank you very much, everyone. Thank you, Dr. Mehta. Thank you, Dr. Kansal.
Thank
Thank
you,
you,
ma'am.
Dr. Gaurav. And thank you, Dr.
Great.
Srikanth, for sparing your time. It's been wonderful to have you all both.
Thank you, ma'am. Thanks the team, Voice of Healthcare. Thank you. Thank you so much.
Thank you.
Thank you.